All right, we are live and live and live. Let's take a look over here. So, one back over here with the camera on to our Friday night lives. So, I wanted to share with everybody today. So, today is going to be interesting. We want to cover three different topics for you guys. And every week, what I do is I try to look for the latest research for you guys. I try to bring it towards you so you guys get a chance to see the latest and greatest of what's happening. Today, we're going to cover three different topics. The first one is going to be a type of fasting called fast mimicking diet. So remember, there's intermittent fasting, there is periodic fasting. Today, we're talking about specifically periodic fasting. So we'll dive into that. And then I also want to make sure that you guys get a chance to hear about this new report that came out from Consumer Reports regarding the amount of lead and sodium that's found in these packaged meals for kids called Lunchables. It's really important that you understand why this is such a big deal, even though a lot of folks are trying to downplay it. But let's make sure you guys have a good understanding of it. So we'll cover that as well. And then finally, we'll get into D-Mannose. And the question is does it work for urinary tract infections or not? So with that being the case, let's go ahead and dive in. And before we dive in, for those of you guys who are live right now, if somebody can put in the chat that you guys can hear me okay, that you guys can see me okay, that would be awesome, just to make sure that I don't find out 20 minutes into this that nobody heard a single thing I said. So I'd appreciate it if you guys just let me know in the chat if you guys can hear me and see me okay. Okay. Holly, thank you so much for yes and yes. I love the double yes. So good evening to everybody. Let's start off with this concept of metabolic syndrome. Now, metabolic syndrome isn't, of course, anything new. We've been talking about it forever. We've talked about all sorts of treatments for it. We've talked about the medication side of things. We've talked about diets for it. We've talked about weight loss strategies for it. And just so everybody on the call understands that when we talk about metabolic syndrome, we're really talking about a combination of three of the following things. So either you have insulin resistance, abnormal lipids or cholesterol, or what we call dyslipidemia. You have elevated inflammation levels. Now, that could be because we measure it through CRP. And the fourth one is if you have abdominal obesity. So, looking at these four, if you have three out of the four, then by definition, you have metabolic syndrome. And if you're wondering what that really means for the US population, about a third, specifically 37% of the US population, has metabolic syndrome. And if you're over the age of 60, that criteria jumps up to 49% of the US population over the age of 60 is considered to have metabolic syndrome. Why should you care? Because the risk of dying from cardiovascular disease, remember stroke, peripheral vascular disease, or heart attack, all fall under that. So the spectrum of cardiovascular disease and dying from that is where it becomes really important. So this comes into the question of diets. We've been talking about different types of diets for a while. And when it comes to fasting, we've done a lot of videos on time restricted eating. Remember, time restricted eating, the concept is you may have an eating window of 6 to 10 hours and you're fasting the rest of the time. And what we tell folks is for the fasting period, you want to try to do that more in the evening. For the eating period, you want to do it when the sun is up. So in other words, it would be great if you started fasting, let's say at 8 a.m. and you were done by 4 p.m. Or if you're doing for a 10-hour fast, you did 8 a.m. and then you were done by 6 p.m. And this way, when the sun is up, that's your eating window. When the sun is down, you're done. Lots of very interesting data, but probably the best thing about time restricted eating is that it helps you to get self-control. It helps you to build discipline. But for some people, it turns out that trying to do intermittent fasting is too difficult. It's just hard for them to stick. So remember, time restricted eating is one type of intermittent fasting. So for those of you guys out there, you may have heard of Dr. Walter Longo and the fast mimicking diet. Basically, what the plan there is essentially it's a 5-day program. It's done usually once a month for about 3 months or so, and then it can be done sporadically. But it's a 5-day program that tries to mimic a 5-day water fast. We don't recommend doing a 5-day water fast because you can get electrolyte derangements or electrolyte issues that can be quite dangerous. And this is why when you're doing fasting, it's easier for you to do this fast mimicking diet. What happens here is in those 5 days, there are specific food packets that his program calls for. And it's basically foods that are rich in unsaturated fats, low in protein, low in overall calories, and low in overall carbohydrates. So the concept here is that you are really around 1100 or less calories. You're not getting a lot of fat. You're not getting a lot of sugar in the diet. Now, there's healthy fats and lots of healthy fats, but not the saturated type of fats, and the protein is low. When you look at the data on the longest living people on the planet, what you'll find is that they actually eat, on average, what we as Americans would consider a low protein diet. So then comes the question of, well, how are you going to build muscle if you're not eating protein? Most of us who eat protein, we're not working out enough to use all the protein we take in. So we end up filtering it through the kidneys. And that's why it's a misnomer to say you need protein to build muscle. Physiologically, yes, you do. But the real world is that a lot of us aren't doing enough to use the protein we're eating. And in America specifically, we actually don't need to eat as much protein as we do. There's a lot of myths. Anybody who wants to lose weight is told eat more protein instead of being told get rid of the junk food, reduce your overall caloric intake. That's a better recommendation than just saying eat more protein. So, what is this thing about fast mimicking diet when it comes to aging, and why should you care? So, the study that's just published, and this got published in 2024 in Nature Communications, is just out. I will have the reference for you guys in the comments when we go ahead and put this video up. But the last name of the author, and I don't want to butcher it, but it's Brandhorst and colleagues. And the title of the study is Fast Mimic Diet Causes Hepatic and Blood Marker Changes Indicating Reduced Biological Age and Disease Risk. Once again, just published this year. So it's essentially 2 clinical trials. They were doing, once again, 5 days of fast mimicking diets for about, on average, 3 to 4 months. And so the study was looking at data for about 184 participants. These guys were 18 to 70 years of age. So the reason it matters is it may not apply to people older, and of course may not apply to people younger. And there's 2 clinical trials. And in these clinical trials, these folks went to 3 or 4 cycles of 5 days per month of fast mimicking diet. And the way it was done was it's a crossover design. So the ones that were initially doing the fast mimicking diet, they got switched over to a normal diet. And the ones doing a normal diet, they got switched over to a fast mimicking diet. But what's interesting is one group was the normal diet versus FMD. Then the other study was Mediterranean diet versus FMD. Remember, the definition that I always give of a Mediterranean diet is it's a plant-based diet plus you get to have some fish. I know that's not the legit definition that some of us are used to, but that's a very good diet to sort of understand and go by. All right, so what did they find? What makes this study so interesting is they actually did a lot of very cool assessments. So in 15 volunteers, they looked at their MRIs and they looked at their BMI. So what they've looked for MRI was exactly how much adipose tissue or fat tissue they have so they can get an exact answer. And the results that were significant was that just doing this 5 days of 1100 calories or less fast mimicking diet per month, just 5 days, in other words, 25 days, you got to eat whatever you wanted. They had a statistically significant difference on lowering their body mass index, on lowering their total body fat, on lowering the amount of fat that is under the skin, what we call subcutaneous fat, on lowering the dangerous fat, which is around the organs, and on lowering the fat inside the liver. And what's fascinating about this is, in addition to all that, they saw that there was a 50% reduction in the fat found in their liver. And this was seen in 5 people out of the 15. In 5 of the 15, they had a 50% reduction after doing 3 cycles of how much liver fat they had. These results, guys, these are just outstanding results to show that something as simple as 5 days of essentially what I would call a low calorie diet that's composed of healthy foods, high in unsaturated fats, low in protein, low in carbohydrates, what it led to. And so the part that becomes really interesting in all of this is when they look at markers for sugar. So, in other words, when they looked at these participants, 11 of the participants had prediabetes and they had insulin resistance to begin with. There was a statistically significant drop in their insulin resistance. And for those of you guys who are familiar with hemoglobin A1C, their A1Cs dropped from 5.8 down to 5.43 on average. That is a substantial drop in their A1C. And this happened after the third FMD cycle. So, in other words, in 90 days of only doing 15 out of those 90 days of essentially doing this diet, they have such a dramatic result. And then when they looked at things like the lymphoid to myeloid ratio, the reason this matters is because myeloid cells are a sign of younger cells. And what they found was that all of the study participants had an improvement in the lymphoid to myeloid ratio, indicating that there was an aging reversal happening. In other words, their biological ages were actually getting better. So, what does that mean for everybody? Well, the bottom line is that they estimated the median or middle biological age of these participants in the study to go down by about 2.5 years. Now, here's probably the most important thing I'm going to tell you about this study that I want you guys to take away. And the most important thing that I want you to know about the study was that this drop in biological age that occurred, it happened irregardless of how much weight they lost. So, in other words, they lost all this weight, and on top of that, they have this biological aging that's happening, and the biological aging that's happening is not dependent on weight. There's a completely separate mechanism. And that's why if you're there thinking about, hey, what does that mean for me? What does that mean for my future? Fasting, however you want to do it, intermittent fasting or time restricted eating or alternate day fasting or once a month of doing a fast mimicking diet, all of these things, their benefits go so much beyond just the simple weight loss part. And that's what I want you to take away from this is the weight loss is good, but fasting has tremendous number of benefits beyond this. Now, let's make sure you guys get a couple of warnings here so you guys can take those with you. And then we're going to dive into all of the questions that you guys have for today. So remember, if you have any questions, please feel free to pop those in to the chat, and then we will get to them in just a second. Consumer Reports just put out a report essentially warning of lead and sodium in Lunchables. Now, if you don't know what those Lunchables are, if you have kids, if you have grandkids, or even yourself, if you use them as snacks, you will find them at every single grocery store. And what they are is they're highly processed meats. And so what happens is what they found in their examination of this, even though none of these products, they exceeded regulatory limits, what was interesting was that out of the 12 products they tested, 5 of them had exposure of 50% or more of California's maximum amount of lead or cadmium. So why should you care? Because over time, can you imagine if somebody's consuming this over time? Heavy metals are very hard for your kidneys to excrete. They end up depositing inside tissues, inside brain, every part of your body, including the kidneys, and they lead to kidney failure over long term. But in kids, what we worry about is developmental issues that can occur because of heavy metal exposure. And that's why you want to understand this. The other part of this, which was really concerning to me, was the fact that when they looked at specifically a 3.2 ounce of turkey and cheddar crackers stackers lunchables, what they found was this one, this turkey and cheddar cracker stackers, had 74% of California's allowable level for lead and 49% of the daily recommended salt intake for kids ages 4 to 8. Why should you care? The recommended intake for salt for kids is about 1,500 milligrams, 1,500. One tiny, teeny lunchable meals, which actually doesn't have a lot of calories, it's giving you around 700 milligrams of sodium. So, in other words, we have our kids getting exposed to salt, getting exposed to sugar, and getting exposed to fat at such an early age in these packaged foods that they get so hooked on them that later on in their life, it becomes very difficult for them to be able to make healthier choices. If you've been doing something lifelong and now you try to make that switch to doing something healthier, different, it becomes very difficult. And then the last thing I want you to understand as you hear all the media go on about this and say how this doesn't really matter, it's not that big of a deal. Here's the thing, we actually don't know if there's such a thing as a safe level of lead for kids. We don't know. So, my recommendation is as much as you can, avoid processed foods in a package, and that includes things like Lunchables and other products. There is still nothing as good as homemade cooking. And for the dads that cook or the moms that cook, listen, your cooking is unbelievable. It's amazing, it's delicious, it's tasty. Don't forget all of that and definitely use it. And then the last study that I want to make sure you guys hear about is about women. Men get urinary tract infections, but it's very, very rare. Women can get urinary tract infections and they're very painful. And in some folks, they can be recurrent, meaning they just keep happening despite lots of antibiotics. So there's a lot of things that we look for in, is there any treatment out there? D-Mannose is one of those things. You can buy it over the counter. A lot of my patients that I know have been doing it because there is some data that said it would prevent bacteria. So it's basically, it's a saccharide, it's a sugar, but D-Mannose is a monosaccharide, and it says that essentially it works by preventing bacteria from sticking to the inside of the bladder, of the ureters, etc. So that's the concept behind D-Mannose. But the ultimate question is can D-Mannose go ahead and prevent urinary tract infections? And so in regards to that, and looks like RD is saying no sound, no visual. Can everybody else see me and hear me, or nobody else is actually seeing the visuals on this? So if somebody would be kind enough to put this in the chat, I would appreciate it. All right, so excellent. Thank you, Tyler. I really appreciate you answering that. Okay, thank you, Barbara. Appreciate that as well. And Casey, thank you. So with the D-Mannose study, this was a two-group, double-blind, randomized, placebo-controlled trial. This is the highest standard of trials you get. And this took place across 99 different primary care centers in the UK. So the participants, they were recruited in 2019 to 2020. They had 6 months of follow-up. They were female, 18 years of older. And the thing that was important about them, they had to have at least two urinary tract infections in the last 6 months and three urinary tract infections in the last 12 months. One of those conditions needed to be met. And the question they asked was, if we gave those women 2 grams a day of D-Mannose, mannose is Mannose, D-Mannose powder, or we gave them just a sugar powder, a placebo powder, would there be a difference? And so the question really was what is the episodes of urinary tract infections happening in the essentially placebo group or the D-Mannose group? So they had 598 women that were eligible in the beginning. Average age was around 58, 18 to 93 years old. 303 were randomized to receive the D-Mannose. 295 got the placebo or sugar. And here's the most important part. What they found was that 150 of the 294 ended up getting UTI that were essentially part of the D-Mannose group. And the ones that got the sugar pill, it was 161 of the 289. So bottom line, there was no statistically significant difference. And this becomes really important because if you're going to spend your money on hard earned supplements and you work so hard and you're like, should I go ahead and buy D-Mannose? This is a very good trial. It's Hayward and colleagues, published in JAMA Internal Medicine, very reputable journal, just published on April the 9th. And their final conclusion is that daily D-Mannose, 2 grams a day of D-Mannose powder, it did not reduce the risk of having recurrent urinary tract infections. So bottom line, D-Mannose at this time, it's not recommended to prevent recurrent urinary tract infections. As we get more data on urinary tract infections, I'll keep you guys posted so everybody gets a chance to hear about this. Okay, so with that, let's go ahead and look at our questions for this week and see if we can answer some questions for you. D. Dutton, hey D. Dutton, how are you? So it looks like if hyperfiltration is abruptly inhibited by inhibiting intraglomerular pressure, does the leakage of protein and albuminuria drop shortly thereafter? So the answer is if you shut down the blood flow to the kidneys, which reduces the pressure on the kidneys, and let's say you clamp it, the protein in the urine by definition will drop. And it's because the blood flow is not going there, and that would happen very, very quickly. So we're talking not weeks, not days, but minutes and hours, because you're shutting off the blood supply. There's nothing coming out. So the answer to that is that would be very rapid as far as that goes. When we look at ACE inhibitors, ARBs, or these medications that reduce the protein in the urine, the way they do it is you have the afferent arterial, you have the efferent arterial, and not to get too technical, but they basically open the end channel, so there's less pressure that's filtering into the kidneys. That's all that's happening. So anytime you reduce the filtering pressure in there, it will make a difference. All right. Tyler said, hi, Dr. Hashmi. I hope all is well. My albumin creatinine ratio went from 386 to 78. Well, that's actually really, really good. So the question is, will 78 cause ongoing damage or not much? So the answer is no, not much. And Tyler, what I would say is that's incredible. Congratulations on doing such a phenomenal job. And we can always make our good better. There's no such thing as best. So I would say keep up the good work. Remember, blood sugars matter, blood pressure matters, weight matters. Those are the three basics you can always do. And then in terms of medications, there's ACE inhibitors or ARB, so lisinopril, enalapril, etc., or losartan, telmisartan, irbesartan. Those are the ACE inhibitors, the ARBs. And of course, there are the SGLT2 inhibitors like empagliflozin, dapagliflozin, all the flozins. D. Dutton said there's a fixed dose of macitentan and tadalafil combo. Got FDA approval for PAH. All the best for your family. Thank you so much for that. the challenge whenever they do that, the drugs end up becoming so expensive that it's very difficult. But as you know, my wife is on ambrisentan, and she is on sildenafil on top of that. But you know, tadalafil, as you know, has a longer half life. It works better. Macitentan in studies is better than ambrisentan, but it's so exciting that things are moving. I wish, like other countries outside of the United States, these drugs wouldn't cost as much as they do here. Let's see. Casey Franco. Hi, Casey. Casey said, should everyone with CKD get a coronary artery calcium test, or just certain people? Should we all see a cardiologist? So, Casey, the answer is no, because what does a coronary artery calcium test tell you? You know, the more coronary artery calcium you have, you're not worried about the calcium that's already hardened. That's not the calcium that's going to kill you. The calcium that's going to kill you is the soft calcium, the soft plaque that's going to rupture. But the hard plaque that's already there, well, it's already hardened. It's not going anywhere. So I don't know what a CT scan or a coronary artery calcium test will add to that in terms of that. I think the risk factors there are very important. Now, I'm not a cardiologist. So this is where, you know, what I've heard from my cardiology colleagues is that there are concerns over people essentially looking at the test in a wrong way. Meaning, if you're on a statin or anything else and you have taken that soft plaque and hardened it, you have actually reduced your risk of a coronary event. And even though your calcium score might be higher, it doesn't necessarily mean your risk went up. Van said, hello. Hi, Van. Thanks so much for joining. And Casey asked, Tyler, how did you get your ACR to go down medication? And Tyler says from losartan. Remember, losartan is an angiotensin, what we call not an ACE inhibitor, but an angiotensin receptor blocker, or an ARB, just another type of medication. So awesome. Tyler said, good evening. Good evening. CK Jamon said, good evening. Let's see. Valsa said, my PTH is high. Vitamin D is 85. Taking vitamin D supplements, can't tolerate calcitriol. Am I on the right track? So, you know, when you say, Valsa, when you say your PTH is high, it depends on what your underlying CKD status is, because the only time that we have actual data to confirm where PTH should be is essentially in CKD stage 5, where we talk about ranges between 150 up to 500. Everything else is sort of consensus driven. So those values are not as clear in terms of where that should be. And, you know, if you can't take calcitriol, I'm assuming that you have issues with the other ones too, like Hectorol and etc. So we have other options there that we can help in terms of helping to lower PTH if needed. But it really depends on what the PTH number is in correlation with what your CKD status is. Casey said, is bilberry extract safe for CKD? Is added to lutein, xanthine supplements for eye health? You know, I'm not aware of bilberry damaging the kidney, so I'll be sure to see if there's any studies out there. So let me get back to you, but to the best of my ability, I'm not aware of that. So I'll let you know. Let's see. D. Dutton asked the question around ADMA inhibits endothelial nitric oxide and its role in the maintenance of vascular tone and structure. It's renally essentially disposed, so can it accumulate? So do you ever check it in your patients? So D. Dutton, no, I do not check it in my patients. And to the best of my ability, I don't know if any of my colleagues who also check it. So I'll ask around and see if anybody else is checking it or not. But to the best of my ability, no. Teresa said, is losartan good to preserve the kidneys? So the answer to your first part of your question is absolutely it is good, because what ends up happening is losartan is going to take the pressure off the kidneys, and it's going to lower the systemic blood pressure. Remember, you got to not only lower the systemic blood pressure, which is the blood pressure in your body, you also have to lower the blood pressure in the rest of your body. And then she asked a question about Corendia. Corendia is a drug that, one, it is kind of expensive. It's Finrenone, and Finrenone is something we're starting to see more and more usage of. And yes, there's very good data in terms of CKD, especially in type 2 diabetics. So the answer to that is yes, we do use it. It is very helpful. Right now, it also happens to be quite expensive, so it hasn't gotten the wide stream attention. But yeah, it's going to definitely get more and more popular as time goes on. D. Dutton said avocados contain an antifungal, so can help prevent fungal infections with SGLT2 drugs. D. Dutton, I really don't know if there's any data correlation to say that avocados could prevent it. If you got any studies around that, I would love to see them. But to the best of my ability, I have not come across anything yet. And then Carol asked the question, before I do that, I've also said, what's ACR? It's albumin creatinine ratio. And then Carol asked the question, is there any evidence for hydrolyzed collagen powder? Carol, unfortunately, not a whole lot. It was sort of popularized in the keto movement for a while that collagen powder would be good, and there were a lot of touted benefits. But if you're looking for protein, you're not really getting the most bioavailable form of protein through collagen anyways. There are much better sources of protein there. So there's some benefits to the skin, and that's definitely seen with collagen powder in terms of how your skin looks. I think I'm a little bit hopeless as far as that department goes, so no, not for me. Okay, let's see. And then our final question is CK Jamon asked the role of diuretics and creatinine. So remember, when you take a diuretic, you're trying to get rid of water from your body, except you can't remove water directly from your body. So what happens is diuretics will remove the water that's inside the blood. As they remove it, then because of pressure differences, water will get sucked out of tissues into the blood, and the next time you take a diuretic, you'll take it out. Now, because they're only affecting the concentration of your blood, you can make it very concentrated or dehydrate the blood itself. That will make the creatinine level rise because you're concentrating it. Not enough creatinine is going through the kidneys, so it's staying inside your body. So when you're on diuretics, you can see that your creatinine will increase. But we monitor that because we're making sure that you're not getting your creatinine rising too much. So spironolactone is a great blood pressure medication, will lower the protein in the urine, and of course is a diuretic, but it's mild. Furosemide, which is Lasix, because it lasts 6 hours, is actually a better diuretic in the sense of just trying to get rid of water, but it doesn't have the same blood pressure or anti-proteinuric effects. All right, with that, it is Friday. I hope you guys have an amazing, amazing weekends. I'm so grateful that you spend your Friday evenings with me. Remember, the greatest compliment you can ever give me is just to go ahead and spread the knowledge around these podcasts. Is every Friday, half an hour, very short, to the point. What I try to do is bring you the latest and greatest studies. So I hope that's of value to you. With that, my message to everybody every time is you could be anything, so why not just be kind? So with that, please spread a little bit of kindness to somebody today, over the weekend. Do something nice. And I promise you, it will be more health for you, more happiness for you. Your kidneys will thank you for it. Kindness is one of those secret drugs that nobody talks enough about. So with that, thank you guys. I'll see you guys next week. Bye-bye.